Good afternoon, everyone. Thank you for joining us this afternoon for our fourth and final Millennium Seminar of the 2007-2008 series. These seminars have allowed faculty, students, staff, and community members to come together to listen and to reflect on topics that have gained national and international attention. Topics have included underage drinking. We heard from the Surgeon General of the United States. The Green Millennium, a panel discussion led by Charlie Rose. And the role of education in the global economy from Secretary Reich. Please join me in thanking the person who has put in a great deal of time and effort in organizing this outstanding series this year, First Lady of North Carolina, Mary Easley. Thank you very much. And I might just add that that's part of her duties as it relates to being a faculty member at a great university. It's now my pleasure to introduce our speaker for this afternoon, President of the University of Miami and former Secretary of the United States Department of Health and Human Services, Dr. Donna Shalala. Secretary Shalala has had an accomplished career as a leading scholar on the political economy of state and local government, holding tenured professorship at Columbia University. She was then Assistant Secretary of Housing and Urban Development in the Carter administration, then became the president of Hunter College of the City University of New York at the age of 33, I might add, and then Chancellor of the University of Wisconsin at Madison. In 1993, President Clinton appointed her Secretary of the Department of Health and Human Services, where she served for 8 years, becoming the longest-serving HHS Secretary in our nation's history. In this role, Secretary Shalala directed the welfare reform process and made health insurance available to an estimated 3.3 million children through the approval of all state children's health insurance programs. She also raised child immunization rates to the highest levels in our country's history. She led major reforms of the Food and Drug Administration as it related to the drug approval process and the food safety program there. She revitalized the National Institutes of Health and directed a major management and policy reform of Medicare. In 2000, she received an honorary doctoral degree from North Carolina State University. In 2007, President Bush appointed Secretary Shalala to co-chair with Senator Bob Dole the Commission on Care for Returning Wounded Soldiers in an effort to evaluate how wounded service members transition from active duty to civilian life. Today, she will discuss veterans' rights and health care. Ladies and gentlemen, please join me in welcoming Dr. Donna Shalala.
Thanks very much, Jim. Thank you very much. Thank you very much. I'm very pleased to be here. As an alum, I appreciate the warm welcome back to North Carolina State. I take with great pride the honorary degree I received here during the tenure of Chancellor Mary Ann Fox. You have an extraordinary chancellor here at the university. I'm pleased to be his colleague in the ACC, and as I said earlier today, we always seem to be on the same page. I've come here today to talk about a difficult subject for our country and for the students here, and since we're sponsored by Blue Cross Blue Shield, who I really need to thank for their sponsorship of my presentation, I want to make certain that I put it in context, that is the context of the entire healthcare system. I, of course, want to thank Mrs. Easley, who twisted my arm to take part of my spring vacation to come over here. I appreciate your clapping. I assume that there'll be no clapping on Thursday for the University of Miami when we play North Carolina State. I also want to note that I worked for and with Erskine Bowles, the president of the North Carolina University system, who's a great friend and who actually taught me a lot and spoke so movingly of North Carolina, and an old friend of Jim Hunt, one of the great governors in this country who taught me a lot about state politics over the year. I also want to see if my friends Ted and Sarah Wade are here, two very courageous people whose story of Ted's experience as a wounded warrior and the complexity of the military health system shaped the report of the commission that I co-chaired with Senator Dole. And I want you to thank them for their service and for their continual work to improve the quality of care for our wounded warriors. Sarah and Ted Wade. Two very remarkable people, and I know I was told not to leave the light, but podiums make me nervous. I'm a healthcare expert. I actually teach the politics and economics of healthcare, so it's not unusual, and I was not, I mean, you're always surprised when the President of the United States calls you on the phone, particularly when you're walking across campus, and the President calls you, and he actually called me on my cell phone and he said, Donna, your country needs you. President Bush is pretty informal. And I said, yes, sir, Mr. President, what is it you have in mind? I've heard that before. And he said, well, Senator Dole, I was speaking with Senator Dole and Secretary Gates, and you've read the stories in the Washington Post about Walter Reed and the decline in the quality of care, and I want to make sure that we take a very careful look and see what's happening to our wounded warriors and make sure that we're doing everything we possibly can to giving them world-class care. And we need a bipartisan commission, a long tradition in American history. That is appointing Republicans and Democrats and using bipartisan commissions as a way of looking at critical issues. Now, sometimes presidents have used commissions, and governors too, I should point out, bipartisan commissions to get out from under an issue. They just want it to go away for a while, so they appoint a commission. In this case, the president really wanted a report in 6 months, which is also unheard of, because usually it takes a couple of years to write this kind of report. But we agreed to do it, and we agreed to do it in 6 months. Now, I must say, I was reassured because Senator Bob Dole, who I didn't know as well as I knew his wife, Elizabeth and I have been friends for many years. Senator Dole and I had not worked directly with each other, though indirectly, but I knew he was an expert on military health care. After all, he was severely wounded in World War II, and he had experienced the healthcare system and had followed it all of these years and had been a champion for veterans affairs, for the military, and certainly for the military healthcare system. I, on the other hand, was an expert in the general healthcare system with some sufficient knowledge, certainly of VA, but not of the military health side of it. So I had some learning to do, and there was a learning curve. But here's the interesting thing, particularly for those of you that might think, well, if we could just get a single health care system for everybody with one payer, it would solve all of our problems. The military health care system in this country and the veterans health care system does have one payer, the government of the United States. And it's still fragmented, unclear, difficult to use. And so who pays the bill does not necessarily assure us of a seamless, world-class healthcare system. And that's the first point I want to make to everyone, because I don't want you to start by looking at Donna Shalala and saying, another one of those Democratic liberals who's in favor of a single-payer system. Because I think the insight I begin with, and certainly one of our single findings, is who pays the bill, and if you have a single payer of the bill, particularly if it's the government, doesn't guarantee that everything will go smoothly. You have to actually design a system and train people so that everything will go smoothly. My second point is that we are in a different world than Bob Dole was during World War II. Most of the severely injured soldiers and sailors and Marines and Air Force personnel who are severely injured in this war would have died in any previous war. Healthcare has gotten so sophisticated that we can save lives on the battlefield in a way that we could never do in previous wars. The number of soldiers injured to those that have died in Afghanistan and Iraq is much smaller, the number that have died versus those that are injured. And we have saved lives on a battlefield the way we have never been able to before. But the nature of what's happening to them, because of the nature of the explosives, where they're placed in this war, has caused injuries to the brain and traumas and mental health issues and a set of physical injuries much more severe than we have seen in previous wars. So we're dealing with something more complex. We've got a much more advanced medicine than we've had before. But we still have the fragmentation that we see in the general health care system. And so what we did was we went out and listened to people, like the Wades. We actually had them come and talk to us. We set up a website, and instead of saying, what are your recommendations to the government to fix the system, we said something even more important. We said, tell us your story. Tell us your experience with the healthcare system in the military or the VA. Tell us what happened to you and the difficulties that you've had maneuvering the system. And then we went around the country, including here to North Carolina, in the bases here. We visited VA hospitals, military hospitals. We went on to bases. We interviewed lots of wounded warriors. We had hearings all across the country. And we sat and we listened to people. We listened to experts. We listened to people that worked in the military and the Veterans Administration. We listened to people in the private sector who had great expertise in these areas. And I think at the end of the day, we found some things we didn't expect if you had read just the newspaper articles in the Washington Post that had started this in the first place. In February of 2007, the Washington Post reported on a building at Walter Reed Hospital, Building 18, that was just deteriorating. It actually looked like some of the dormitories that we have on some of our older campuses in America. When I saw the pictures, I said, oh my God, I've seen that before. The problem was that we were putting wounded warriors there who were trying to get their outpatient care at the same time, and the buildings were clearly deteriorating. But in the investigative reporting, they revealed not only that the buildings were deteriorating, and they admitted that there were some better buildings that families were being put in, but the system itself of healthcare seemed uncoordinated. And these wounded warriors didn't seem to be getting the best that America could offer. And so those Washington Post articles sparked an outcry, because as the President said, if we send them to war, then we have a responsibility, if they get injured, to offer them the best possible care. And so we started with that principle. Some of my friends rolled their eyes when they heard I was going to go work on a presidential commission for President Bush. But here's my attitude about that. Last night I hosted a dinner for 15 West Point cadets at my home in Miami. One of them was my youngest cousin. And his brother had also gone to West Point and serves now in Iraq. Every generation of my family has served this country since my family came to this country from Lebanon at the turn of the last century. Every single one of them has served in some branch of the military. Every generation. And so for me, like lots of particularly working class families across this country, making certain that we not only make the right kinds of decisions politically about where we engage our military, but making sure that they have everything they possibly need to engage in whatever we're asking them to engage in, and that we treat them properly when they return, is personal for me. And so I say this to everyone to remind you that this has nothing to do with political party. It doesn't have to do with ideology. It doesn't have to do with which presidential candidate you support. All of us have a stake in the quality of the healthcare system that we're providing for our military. And that's my attitude, the attitude of Senator Dole and of all the people we work with during this period. Looking at the healthcare system, we discovered a number of things. I've already told you a couple of them. But I think the most important thing from many of your point of view is if you're wounded in the theater of war, every single branch of the service cooperates in a very integrated, seamless way to get you out of there to the best possible care you could probably get out of. Within 48 hours, they can get you back to the United States in a world-class healthcare setting for an operation. There is no question in terms of transportation, deployment, who we have in the field, the way we set up our field hospitals, the quality of the personnel, our increasing integration and embedding of mental health experts in the theater of war. This is the best of times in terms of the quality of what we are doing. And that is, we can get you to first quality care, and we can get you to world-class doctors. And make no mistake about it, at Walter Reed, in San Antonio, wherever we went, at Bethesda, wherever we went around the country, these hospitals are clearly world-class. When you need an operation, you'll get that operation. Where it starts to fall apart is after you actually leave your hospital bed. And in the coordination of care for the individual, having to go back and forth to that hospital or to a rehab center, and all the benefits that are attached to that, how you get separated from the service, what happens to your records. And so it's the outpatient part of that, our failure to coordinate, to make it seamless, to get an electronic record system that interfaces. The Army alone has 3 different record systems, but heaven help us when you have to transfer it over to the VA or out of the hospital. The loss of records, we heard time and time again, the failure to coordinate care, mothers, spouses, uncles, aunts giving up their jobs to move with that wounded warrior to coordinate their care. The stories were horrific about what happened after they left that hospital bed. And if you have to go back in and out for numerous operations, as those who have been severely burned or those that need regular, not simply checkups, but regular treatments over a long period of time, it is very complex. Now, the military has moved in to try to get some care coordinators there. But a member of our panel, and I want to tell you a little about our panel, there weren't very many members of our panel, but half of them, 2 of them were wounded warriors themselves, 2 young men who had served in Afghanistan and Iraq. One had lost an arm, the other had severe injuries to his leg. Both are back in school. The wife of a wounded warrior whose husband was severely burned, over 70% of his body. The head of the Washington Rehab Hospital, a private rehab facility, he was handicapped himself in a wheelchair. And, of course, Senator Dole. So most of the members of our panel actually knew something about the subject from their own personal experience as well. All of those young people who had experienced a system like the Wades had reported just horrific stories about lost records and the lack of coordination in the system. This meant that if we were going to make recommendations to a very complex system, which after all had deployed or had 2 million, at least 2 million deployments, about 1.5 million people were deployed, service members were deployed to Iraq and Afghanistan during this period. About 3,000 severely wounded that needed to be coordinated, but all these stories were just horrific. They were stories about turf and about our failure to get the system to work very clearly. So what we did was what most commissions don't do. We wrote a short report which could be implemented. Rather than giving them a lot of philosophy, we told each branch of the service and the Congress of the United States, but particularly the President of the United States, what he could do and what he needed to do immediately, and made very specific recommendations. And we only made 6 recommendations because we were determined that this would work very clearly and had to be working very quickly. The most important recommendation, from my point of view, that we made was that every severely injured wounded warrior had to have a recovery plan and a single person to coordinate their recovery. And Sarah just sent an email to my office and said the recovery coordinator has arrived, and really took over some of the burden that she's had to coordinate Ted's care. We also said that person should not be a military officer, because one of the things that the young people told us on our panel was that these people kept being deployed. They get a care coordinator, and then the person would be sent off to the theater of war. So you needed a single person that was an adult that was going to be there for a significant period of time and coordinate each part of the rehab process and of the recovery process. And that included the whole benefit structure for the individual. So recommendation was number 1 was, let's appoint one person. Now, where did we get that idea? It's interesting. You always should appoint people that know more than just their subject matter. Because I remembered that a police officer in most of the large cities in this country, from the time that they're shot, has one officer assigned to them until they get completely through their rehab. So Senator Dole and I actually suggested that we ought to cut through the red tape, simplify the system by appointing a single person with considerable power that was assigned to the individual that was responsible for coordinating all their care. The idea of a care coordinator is not unusual in American healthcare. What's unusual is to have one person that goes beyond just the healthcare pieces, but can coordinate the benefit structure too, and can cut across agencies. We'll see how it works. Sarah will be my touchstone on this, but so far so good, right, Sarah? At least it takes some of the burden off of her. Number 2 was, of course, to get all these computer systems to work together. And of course, if you're in Washington, the first thing you want to do is spend billions of dollars. In fact, when I went back to higher education, people would come in to see me with $2 million deficits, and they didn't understand why I wasn't upset. It's because I had lived in a world of billion-dollar deficits, and the numbers seemed so small to me to get upset about. But the fact is that every time we want to solve a problem in this country, we want to throw money at it, as opposed to thinking through what it would take just to transfer those records back and forth in a cheaper way, in a more seamless way. And of course, you can write computer programs to do that kind of thing. We need to be able to transfer a record from the Army to VA, within the Army structure, whatever it is. We need a seamless way of transferring electronic records. We know how to do that. We just need to put those systems together. And so we made a recommendation in that area. And that became an important recommendation. We also made a series of recommendations about benefits. This generation of young people who are coming back want to go to work and they want to go to school. And this country needs to make a deeper investment in their education. One young person said to me that the VA told him he had to go to community college because it was cheaper. And he said, you know, I'm eligible to go to a 4-year college. I want to go to a 4-year college. And so we recommended not only should young people be able to go to four-year colleges, but they ought to get more money for each year they complete. So it incentivizes them to finish 4 years. The dropout rates in the educational benefits look like inner-city high schools. People aren't sticking with them. Now, sometimes we have to remember that some of the people that went into the military went in there because they didn't like high school. They finished, but they didn't like it. So we have to make sure that we have proper programs, but that they emerge from these programs with as good an education and a preparation for life as we could possibly arrange for them. And if they want to go directly to work, and if they can't work full-time because of their disability, then those of us in the private sector, in the public sector, have to make those jobs available. The last thing we need is large numbers of people that don't want to just collect checks but do want to go to work. They need an opportunity to go to work. And those of us who are responsible for creating jobs in this country have to think about people who are still getting treatment but are able to work in terms of the kinds of support systems they need. So deeper benefits, not only for the wounded warriors, but also for their families, to give them the kind of support that they need and to make all of this much more seamless. We had a number of other recommendations that had to do with the healthcare system. Probably the most important one, and the President is in the process of implementing 90% of the recommendations. We were smart enough to give him the bulk of the recommendations that he had the authority to make, and to leave the others for Congress. So about 10% of the recommendations have to be done by Congress. And probably the most important one, which your own senator is working on, is the one that gets the military out of the disability business. That basically says that if you're wounded, and that the military makes a decision after you've recovered whether you're fit or unfit for duty. And if you're unfit for duty, they give you an annuity. They don't wait for your 20 years. They give you an annuity, and you have that annuity for life based on your number of years of service and your rank. And then you get your physical exam, a physical exam designed by both the VA as well as the service branch that you came from. And then you go over to the VA, and the VA does your disability benefit. And it does it based on new criteria, because we've been doing it on old criteria for a very long period of time. We talk about the quality of life as one of those criteria, but the important thing is that if you can't stay in the military, you get that annuity, and there's one place where you go for your disability rating. Now, to a student here, that seems logical probably, but the system now is so complex that you get a disability rating from both the service that you're in and from the VA. Again, the point is to simplify. Simplify is not a word that's usually used in Washington. But we're in a very complex situation here in which the programs themselves are very complex. And along with recommending this, we also recommended a website where you could find out what all your benefits were. So you didn't have to go to the 15 different websites that were set up and were responsible for all of you. So the point of our recommendations was first to improve the seamlessness of the information, the seamlessness of the care, quick and quality decisions about whether you would stay in or leave, making sure you got the benefits that you were eligible for, and doing it in a much simpler, more understandable way. Now, why is it so complex? It's complex, really, I believe, because in government, every time you have a problem or a crisis, you add a new regulation or a new program. We never seem to think something through and then reorganize it in a straightforward way. What we do is we make it more complex by adding a new program, because we're trying to solve this problem over here, we create this problem over here. I think our point is that this generation of wounded warriors ought to get high quality care. It ought to be seamless. It ought to be understandable to themselves and to every member of their family. It ought to be carefully coordinated in a way in which their family members do not have to give up their jobs and their futures to coordinate their care for the rest of their lives. And we ought to invest the kind of money that's necessary to make sure that they have a life after the injury. If we can do anything possible to help them get back to work or into a job that they can do, even if it's part-time, or get to the education that they've wanted and dreamed about, then we ought to make those kind of investments. Will it cost us a little money? Yes. But it's costing us an awful lot of money to fight these wars. And the aftermath of wars ought to get that same level of investment. If we ask people to risk their lives and their futures, then we ought to be able to make that kind of investment. Those are the basic recommendations that we made. It's a way of thinking about the system. It's a way of thinking it through. There have been some objections to our recommendations, not to the ones we sent to the President, but to simplifying the disability system. A lot of the veterans groups do not believe that you should give more to this generation of benefits of veterans than we gave to previous generations. And that's a political call. My own view is that for each generation we ought to do better. That's, after all, what we try to do in education. It's what families try to do. But we also ought to make some of these programs, and certainly the disability ratings, available to everyone if they want to go through the system again. But more than anything else, we've learned a lot over the years about what's appropriate, and we ought to bring our military and veterans health system up to the highest quality. And we ought to accept the fact that mental health is always going to be a part of the experience, and that we've got to get over our macho image of everybody working their way through and start to use the skills that we have to help people live productive lives. Thank you very much, and I'd be happy to answer your question.
Dr. Shalala, thank you very much for your remarks. I'll try to get to as many questions as I can from the audience. The first one says, as we invest more money into this health care program, where will it come from?
Well, if I was in government, I could tell you exactly where it would come from. Well, the point is that we've got to decide where our priorities are. Clearly, at some point, the war is going to end. All of the candidates are committed to some appropriate and safe ending to these wars that we're currently fighting. Most of the recommendations that we had require pretty incremental increases in resources, because we're talking about this generation of wounded warriors. And remember the numbers I gave you. For the severely wounded, we're probably talking about 3,000. For those with either TBI or other kinds of mental health issues, we're talking about relatively small numbers of people, but the centers of excellence must be in the VA for dealing with that. Post-traumatic stress disorder, for example, we have a number of centers in this country for dealing with that. That can pop up at any point. We've said, and the Congress has luckily said, that people ought to have access to that kind of care whenever it pops up. But those, for the most part, these are incremental costs that require reorganization. The educational benefits, we don't know what the new disability system would cost, but I can't imagine that it would cost more than it currently costs for this number of people. Whatever the cost, it has to be a priority in this country.
This audience member writes that the VA has some wonderful resources for their service members. What can the VA do better to let these service members and veterans know how to access these services?
Well, you know, one of the things that we recommended was a website in which people could find out about all these services. You know, this is a different generation. There's no reason to send out a brochure to this generation of soldiers and sailors and Marines and Air Force personnel. They've never seen a brochure in their life. We've got to go to the way we communicate now with the new generation. It's got to be more electronic. We have to use websites. We have to use accessible websites, and a single website would make a big difference. But the way in which we communicate and fund that communication is so old-fashioned. No university would ever do to communicate with their student body the way our government communicates. And so we've got to modernize that kind of communication. More importantly, for the severely wounded, that recovery coordinator better know every benefit that's available to them.
Speaking of that coordinator, the concept, this person says the concept's a very good idea, but were there any limits placed on the care load that a particular coordinator might have?
Well, we obviously have to look at care load. Sarah, come up here. Yeah. We obviously have to make sure about the workload of the individuals, because these are very complex patients. Talk a little about your first encounter with what you see so far, because you were one of the people that made that recommendation to us.
Yes.
This is Sarah Wade. She's from North Carolina.
I believe right now they're starting off slow. I think a lot of why things get bogged down in bureaucracy or programs go belly up is because of knee-jerk reactions. And so they're starting the Federal Recovery Coordinator program off slow. I think there's only 9 to begin with, and they're using a small number of test cases to they're still trying to establish what the caseload is. I think that the plan is to weight loads. Various different loads are going to have a different weight to them. Someone like my husband, who has a severe traumatic brain injury and is not capable of coordinating all his care, is going to have to, have a different weight than, say, a person who's an amputee who may need a new prosthesis every couple years. I think that's the plan so far.
But so far you're kind of pleased with what you've seen.
I've been very pleased. I'm not used to delegating. I'm not used to asking for help anymore, and it's a huge improvement.
Good for you. Thanks, Sarah.
Switching over to higher education for a moment, what will the return of veterans from Afghanistan and Iraq mean for higher education?
Well, I think that all of them will find higher education accessible. The question is whether we'll have enough resources to be able to support them. And I think that was the point that Senator Dole made, that we have to make sure that they're able to go back or start higher education, pursue the things that they're interested in the right institutions. So we have to make sure they get proper counseling for that. North Carolina has done a terrific job, from what I can tell, of trying to get people into institutions and giving them the kind of support that they need. Most of us in higher education both have tracked our existing students, but when people have come in to see us, have someone coordinating that to make sure we put all the pieces together for them. Higher education has a special obligation here.
You mentioned all the many things that are being done for the war here at home, but what are we doing? Excuse me, saving soldiers on the battlefield. But what are we doing here to prevent soldiers from getting wounded?
Well, actually, we're doing a lot of things about equipment, about gear. I just sat next to a young woman here at North Carolina State who's, and North Carolina, and the dean, your textile dean, who actually is doing a lot about equipment and clothing, which is important. This is a very different kind of war, armored cars and different things that we need to do. But when we find out what works, we've got to then invest in it and get it to people in the field as quickly as possible. We have been very slow at that at the beginning of this war. We should have been better prepared, but we're learning a lot in the process. And investing money in that kind of research will pay off in the long run.
You mentioned the larger context of the American healthcare system. Do you believe that the problems that you've seen in the military healthcare is relevant to those of healthcare for regular Americans? And do you think we could apply what we have learned to general healthcare for our citizens? And this question also says, what do you think of a universal healthcare system?
First of all, yes, it will apply. Second, the young men and women and older men and women who are going out to fight our wars are regular Americans. They come back into the healthcare system. They go into the military's healthcare system. We obviously want for everyone a world-class system. We've learned a lot about trauma. And in fact, the kind of training that our field teams are getting, for instance, at the University of Miami, the trauma center at the great public hospital is where these teams, the Army teams, are assembled and trained. Because only in a big city will you see that number of cases, emergency cases, for training. So it's one of the places where we're doing that kind of training. We're learning a lot about emergency medicine and trauma medicine that will help all of us in this country. It's a hard way to learn that lesson, but we're learning a lot about equipment, we're learning a lot about clothing, we're learning a lot about intelligence. I mean, a lot of these things will help us in the long run. I'm not sure I'd go to war for that, but we've made that decision, and now we have to do everything we can to protect people. As far as the larger healthcare system is, everybody's for a universal healthcare system. The argument between the two parties and among ourselves that have stopped us from putting that together is an argument that that has its roots in the 1930s when the American Medical Association raised the issue of socialized medicine and suggested that government should not expand beyond those places where the private sector didn't want to go. So we either build on the current system and fill in the gaps, as we have with children's health insurance, for example, or we start with something new. I think it's very difficult for this country to start with something new. We've got to figure out a way to fill the gaps for those who get up every morning and go to work. The fundamental point here is the people in this country and in this state who don't have health insurance are working. They just don't get health insurance through their jobs, or don't work enough hours to get health insurance, or can't afford it, which is more likely. And there are a lot of people in this country, and I'm sure in this state too, who have lousy health insurance, where they might be better off just paying, to go to the doctor, though I don't recommend that. And for those folks, they need a stronger insurance program. We haven't figured out how to put it together. If you ask me, I'd experiment first in the states. One of the things that I've learned over the years, and maybe it's because I love state government, is that we learn a lot from trying to put together not only the substance of programs, but political coalitions at the state level. If we can get the presidential candidates to really engage on this issue, we might get some help at the national level. But that help might be to support states that really want to get it done. I'm speaking to Mrs. Easley now. Where is she?
Would you please comment further on some of the actions taken by the federal government to help those with post-traumatic stress syndrome?
Yeah, there are some private sector places where you can go for help, but basically the expertise has been developed at the VA. And simply identifying it early has become very difficult. I actually sat in as soldiers were coming back, and they were all being asked whether they felt that they had suffered some trauma or had some concerns and would like to talk to someone in advance of being released. Everybody wanted to go home. I mean, they did not want to hear from any officer. They just wanted to go home. Now, these were National Guard members. Post-traumatic stress can show up in the field. The Army has embedded mental health people to try to work with soldiers when they come back from a deployment where they've gone out on perhaps some kind of a rescue attempt or something and have come back and suffered some trauma, so the mental health people are working with them. So from the field to the training, to right back when people get released, the VA will now provide that service, even if it pops up, some of that anxiety pops up a year from now or 2 years from now or 3 years from now. The problem with post-traumatic stress disorder is the diagnosis and the accuracy of that diagnosis. We've had a lot of experience treating the most severe cases, but not as much those in the middle. But the expertise is always going to be, in my judgment, in the VA. And we've got to make sure that we have the specialists and that we can hire mental health professionals to work with people as they return, over the course of a lifetime in many cases.
Could you comment on the specifics of what has been done since you and Senator Dole's plan has come out by the federal government?
You know, a lot of things have been done. I would guess that more than half of our recommendations have been implemented, with the others in some phase of implementation. We made our final report sometime in August, so they're working through. And the President basically said to Secretary Gates and to the new Secretary of Veterans Affairs, implement it. Secretary Gates took the lead while the new Secretary of Veterans Affairs was being identified. And I think they've worked very hard to figure out ways in which they can put this together. But it's never going to be anyone's highest priority unless the President of the United States makes it the highest priority, and unless the American people keep pounding and saying, we've got to do this.
You mentioned the website a minute ago that would be a great resource. This person asked, how much research will be done into new medical devices that will improve VA treatment, and will the website have links for companies with these new products?
No, it doesn't actually have those kinds of links. It's not a private sector website. It's a website for individuals that are trying to both see what benefits are available, how they apply for those benefits, when their appointments are. It's an integrated website for the patient. Remember, what we tried to do was to develop a patient-centered kind of system. That's the problem with these huge institutions. The institutions drive the decision-making based on their interests as opposed to the patient's interest. And just like we've tried to transform higher education, looking at it from the point of view of students, the healthcare system has to look at the system from the point of view of patients and their families.
Many veterans live in remote areas which are not near military hospitals or VA facilities. Did the Commission address this issue of providing health care away from the Department of Defense or VA facilities?
We did, and both the VA as well as the military has the authority to contract with private providers to provide that health care. We urged them, where the health care was closer to the individual and where it was appropriate, to let people use private facilities and private doctors. To have to travel long distances to VA facilities seemed to us not an efficient way of providing services, and there is some small amount of contracting that's going on. There ought to be more. The problem is there's no incentive for it, because if you're trying to keep your institution alive, you're trying to keep patients coming into it. So we have to make sure that the individuals that run the institutions don't see a downside to doing that. But they certainly have the authority to do it. They ought to be doing more of it. My sister and brother-in-law live in rural North Dakota. And while it would be a very long distance for them or for their children to have to get care, and in some cases there's appropriate care in their area, in other cases there isn't. But where there is, we ought to keep people as close to home as we possibly can.
Could you provide us some true cost of the current war if health care is part of the calculation?
No. That's not my area of expertise or anything that I've looked at in particular. And frankly, the President didn't say to us, money is a problem here. He said, you tell me what's necessary, and I'll get it done. And I listened very carefully. And Senator Dole heard the same thing I did, so we went on with that assumption. But we also, if it took reorganization of the system, it looked to me like we had to do more reorganization than pouring millions of dollars into it. We're spending an awful lot of money now. We need to do it right.
What consideration has been given to the children and families of military personnel and veterans?
Well, we made some recommendations about TRICARE, the healthcare system the military has for the entire family, and about support systems we made a number of recommendations for family support systems and investments in those support systems. There are a number of bases that have Fisher houses, for example, and Ken Fisher was a member of our panel, which house families while a loved one is getting treatment. We need more of those. We also need more support systems. As any a spouse can tell you, They have to give up a career to do that coordination. We need to substitute for that. That should not have to be the responsibility of families. It ought to be the responsibility of our institutions themselves, and then we ought to support them to enable them to pursue their careers and their jobs and support their families while their loved one is getting treatment. And all of those are recommendations of the Commission.
Got one final question, Dr. Shalala. What message, or perhaps more importantly, what action can students here take today with them as they leave?
Well, when I talk to young people, there are a couple of things that I say to them. Number one, you ought to thank every student on your campus who has served or walking around who's a member of the ROTC, because they're representing and serving all of us. Second, that you better go register and vote. This election, no matter what your choices are, all of us need to put pressure on all the candidates, no matter which party we belong to make sure that we do the right thing if we ask people to take huge responsibilities. And this election, I believe, is a defining election for the generation of people that are currently in college. You ought to pay attention to the issues. You ought to know the position of the candidates. You ought to think thoughtfully about who you're going to vote for, because it does make a difference when you vote in this country. But more than anything else, on an individual basis, we have to thank all of those who have served all of us. Whether you agree with the war or not, to me, it's irrelevant. What is relevant is when we ask people to serve our country, they step up from every corner of our country, from rural North Carolina to the big cities of New York, and we need to make sure that we honor those who serve. Thank you very much.
Dr. Shalala, let me thank you on behalf of North Carolina State University for a very informative, thoughtful, sensitive, and caring presentation. Please, another round of applause for Dr. Shalala. And thanks to each and every one of you for being with us this afternoon. This concludes the seminar. Thank you.